Thank you for watching the Calhoun County Medical Control Authority COVID-19 update. EMS provider Q&A session by Dr. Chapman.
Well, good afternoon, everybody. I want to start off by thanking each and every one of you for providing a vital community service at a time of national disaster. You know, it takes a special person to walk into something that many people feel is a scary situation, and to do so bravely, courageously, to provide necessary care to our community. So I do thank all of you for that. No, I'm not a speechwriter, so it's not very elegant, but I do sincerely appreciate all that you do. So this situation is one where we've had some emergency protocols come out through the county, through the state. But I wanted to take the time to begin by answering basic questions that you might have. I want to try to ensure your safety, but I want to also make sure that whenever possible, I can win your confidence on this. So I want to open it up to any questions that you may have about anything at all so that we can answer this and try to keep you guys safe and sane out there. So feel free to take yourself off mute, and I apologize for not having video, but trust me, you don't want to see me. Do we have any questions out there?
Are you going to be, this is Julie Maston, are you going to be activating the teleconferencing protocol anytime soon?
Well, thank you for asking that. So I will tell you, just 15 minutes ago, I tried to do this with over my cell phone with one of Marshall's team, and the video worked wonderfully. It was very nice, but I could not hear a thing they were saying. So I'm game for doing this as long as we have a mechanism to make sure that we have others besides just me answering it. Fifth District is immediately after this call having a conference where we're going to be discussing shared responsibility, shared medical control for these types of calls. But I believe it's safe to say at our meeting with the board members of the CCMCA, we got a tentative approval. So if testing goes forward and everything seems fine, I am good with going on it.
The other protocols that the state has put out, have we sent in our acknowledgement that we're going to adopt those?
So Mark is sending that right now on my behalf. We are accepting all of them, and I did so in an emergency manner because they were emergency protocols. The board, I hope, is okay with that, but because they are emergency protocols, I felt there was an urgency, so I had him go ahead and submit to the state our approval of all of them.
They have been advised.
I'm sorry?
They have been advised.
Excellent. And I believe the app has been updated. Is that correct too?
That is, so I'm going to double check that, but I put those out to him to post on the app soon after they came out.
Excellent. So we'll just need to double check to make sure that's there. What other questions do we have? Do we have any questions about the spread of this, how it spread, what we can do to stay safe, anything like that? So originally, hearing no questions, originally, if you had contact with a person, you had to be in quarantine for 14 days. I want to assure you that the state and the CDC have lifted that restriction. So based on your degree of exposure, they have different requirements. The first is if you screened a person and thought that person was a potential person of interest or person under investigation, you could, and if you donned your mask and all your gear, That's considered a very low risk of transmission. With that, you just go back to work unless you develop symptoms. However, the other version, the other potential exposure, is if you were transporting a person and you didn't think that they were necessarily a coronavirus patient, but you were, once you got to the hospital thought you were. That would be a higher degree of risk. And what we do in those cases is we ask if you're symptomatic or not. If you're not symptomatic, we ask that you check your temperature twice daily, preferably 8 hours apart, and to notify your superiors if you have any symptoms consistent with COVID infection or coronavirus infection. That is sore throat, temperature greater than 100, cough, difficulty breathing. So if you had those before the exposure, it's not really something new. But if you developed it after the exposure, then we may have to take you out of service. If we took you out of service for high risk and you were starting to experience symptoms, it would be for the greater of the two of either 7 days or 48 hours after a fever has ceased with no antipyretics, no Tylenol or Motrin or Aleve or any of those. So they have changed these significantly. The other thing is I received notice from the health department if there was any potential risk to any of you. They either call me or email me when a test turns positive, at which point I call you and have a conversation with you to help risk stratify. We have had 2 individuals already where I have had to make a phone call to them yesterday in coordination with the county health department and the agency involved. They were deemed to be rather low risk, so they're going to monitor their symptoms. So it is important with your care records that you put any potential exposure, put in there if you were wearing masks and things like that. Note in there if you thought that this was a potential person and you gloved up, gowned up, all that good stuff, PPE. So putting that in there will help. There's a question in here. It says, the unfortunate thing is there's just not enough PPE anywhere in the country, and soon not much extra in the world. We have access. Steve Frisbee has specifically accessed the stockpile, and we received a very small portion of what we requested because everybody is requesting. So now that we have community-based spread, this is a very difficult thing. So, and this is why the app is important. If you have a person who calls and you go and you screen them, it's staying 6 feet away, ask them shortness of breath, cough, fever, and exposure to any known coronavirus patient. Those are the questions we're using. But again, I think we're going to get to a situation where a lot of people are going to answer yes to that. For me, where this app can come in handy is if this is a low-risk person whose vital signs are normal, who can have conversation with you, the safest place for them is just to stay home. We do not have approved treatments. There's not much the hospital is going to do if the person is stable other than test the person. And we don't have sufficient tests, so the only people who are getting tests right now in the state of Michigan are the sickest of the sick. So the way to conserve is to not transport these patients. But in order to not transport, we really need this telehealth app to work. I hope that answered your question. If not, feel free to clarify. What other questions do we have out there, folks? Any rumors I can answer? Any falsehoods out there? I want to make sure that I'm available to you for anything you wanted to discuss.
I have a question.
Yes. Is this Vince?
Yes, it is. I've heard rumors about it possibly mutating again and involving more non-fever related symptoms and also gastric symptoms.
So the funny thing about viruses is that they mutate quite easily and quite regularly. So we took meaning the medical, took samples from Africa, and you heard Nairobi, Africa had a high involvement rate, and it was assumed that they came from Chinese spread. However, through genetic sequencing, we could see that it was actually genetically mutated slightly different, and we could say because of that, it came from Europe. So this virus mutates frequently, but its close cousin, which was called MERS-CoV, which is still involving the Saudi Arabian Peninsula, it did have a large amount of GI involvement. So we're seeing about 30% of people, give or take, initially have some degree of GI involvement, such as diarrhea. The problem is that we just don't have enough epidemiological information right now to really say. So yes, as viruses spread, they mutate frequently. Usually the degree of mutation is small, but it's enough to allow us to see where a particular strain came from. The symptoms, early symptoms, that's why we've added like sore throat. We started to see a lot more of that in this country, but we have not been able to officially say GI things because the CDC just hasn't seen enough. But they have, there is a lot of stories of that, in particular the Seattle bunch. I hope that answered your question.
Yes, it did. Thank you. And what about them having fevers? I've heard that rumors of sometimes they're coming back positive, but not having a fever. But we shouldn't be testing people that don't have fever, should we?
So right now, the only people we're testing, and I have to be very specific about these terms. So there's screening, sampling, and testing. So we can screen everybody. I have a phone number for people to be screened. You asking questions screen people. Then there's sampling. Sampling is done at specific locations such as hospital or sampling site that Oakland has right down the road. And then there's testing, which is doing the PCR test to actually see if the virus is present. The only people right now, because of the few number of tests that can be run, the only people that are being truly tested are the ones that pretty much are the sickest of the sick. So almost all of them have fever. The few that don't are high-risk individuals, such as care providers, yourself included, docs like me, who have been around sick folks who are confirmed and have developed symptoms. Those people are getting tested irregardless of fever because of the high risk. How was that for you? You're shaking your head. I think that's good.
That's good. Thank you.
You're welcome. It's enough for you to know as an EMS provider to put a mask on. Simple mask is sufficient at this point, especially if when you get there, you quickly put a mask on that person. To be honest, anybody who has anything respiratory right now, get a mask on them if you can. If you have to do any procedures with them, you should be wearing a higher degree of mask if available, such as an N95 if you can get access to it. If you cannot, making sure the patient is masked and yourself are masked is appropriate. So any screening they do beforehand that lists respiratory issues, just as precaution, I would ensure that you have your mask and that you're ready to mask the patient. So this is something that was hotly debated today at the hospital. And I cannot assure the safety of providers who choose to wear that in high-risk situations. What a homemade mask is very good at is preventing a patient from creating droplets. So I don't mind as much if a patient wears one. I get a little more concerned if a provider wears them in a high-risk environment. Remember, you're in a little box that is slightly bigger than a coffin, and if you're in there with a person who is coughing, I get really worried about that. That's a high-risk situation, and that's much higher risk than some of the people in the hospital. So I think that the safest thing for providers is to wear masks that we have assurance as to their quality, but I am not opposed to a patient wearing a homemade mask because it keeps out or reduces as best possible the number of droplets that are formed. In fact, I wish you could see on camera, one of the lovely ladies here made me a green one with pink polka dots that I have here as an example. I can't show you on video because I can't get video to work on this. But for me, the only time I would use this is out in the community if I was scared. But in a high-risk situation, wearing approved masks for our providers is the best option. So remember, testing does not treat you. Testing does not make you better. And we do not have appropriate treatments. So the only people who should be tested are the sickest of the sick. I will be honest with you. We have community spread. You need to take the number of positives that have been reported and multiply it by a factor probably near 100 to tell you how many are actually infected in our community. But since the test does not lead to a treatment unless you are sick and sick enough to be admitted, sick enough where we're making critical decisions on your part, there's absolutely no need to get the test. We can assume you have it if we need to. We can put you in quarantine if we need to for a while, but there's no need to get that confirmatory test unless you're really sick. Again, our actions in this whole process are not just to stop the spread of virus. The virus is here. The virus is going to spread. What we're trying to do is make effort, take efforts, deliver actions to slow it down enough that hospitals can accommodate the surge of patients who will need us. So anything if we do nothing, all the hospitals at about the same time are going to have capacity issues, and then we're going to be in a situation where we're out of control. So all the steps and measures we're doing are just to slow down the spread. But we're already too far behind because we have community spread. So at this point, it's just trying to limit the sick and limit a burden on our hospitals so that we can save them for the sickest of the sick. So testing, no, not right now. We may get to a point where we can run more tests, but we're still so severely limited on the number of tests that we can run. It's just going to gum up the system and waste our precious resources to test otherwise healthy folk. Oh boy, I knew this question was coming. So as I read the protocol, and that's what I have in front of me, there are specific persons who are listed as qualifying patients. If this works, and I do not know if it works well yet for our region, you would be able to call me or another provider, talk to us. I would be able to talk to the patient as well, and I could provide medical advice through the app. I could ask you give give medication X, and you could give it, and we could see what kind of response there was. But ultimately, what this app would do is I could talk to you, I could talk to the patient and say, you know what, it looks like you have an ankle sprain. I don't think you need an X-ray at this point. Ice, elevate, stay off it for 7 days. Do not go to the hospital. So this tool would allow you to relieve the hospital of some of the low-hanging fruit that comes in. Now, we've all had those calls where somebody came in for toe pain and came into an ER, and you were forced, even though your common sense said this person doesn't need to come in, you were forced to transport them to a hospital. And that's not necessary with this. The other thing is we could have you transport them hypothetically to an urgent care or another clinic. So this is to help relieve any stress on the hospital systems. Ideally, the way I would like to see it is to relieve stress on you guys as well. because the fewer transports you make that are not necessary, the more availability we have for when you are necessary, when you are needed. I think Mark or somebody else at the college has put up the protocol here. If he rolls down, under 3, section 3 is where the qualifying patients part is listed. So these are the people who would be potentially able to be assessed remotely and potentially denied treatment or denied transport, rather, to an emergency department. And there could be other things that are included. Below it lists the people who would not qualify for this and would need to be transported to a hospital. I think these are really common sense, and I would trust every single one of you to pretty much know this. You know who's sick and not sick. So if you felt somebody was sick, you wouldn't need to call me in the middle of the night and say, hey, doc, I think this guy's sick. Instead, you would just do what you always do. Trust your gut and go. But if this is something that is a little girl fell down the stairs, stubbed her toe, mom's scared, but the kid's perfectly fine, that's when you're going to call me, wake me up, and I would say, no, they're fine. Call your doc or ICE elevate 7 to 10 days, something like that. So I think that these excluded folks are pretty common sense. I love the labored breathing following treatment. You would never send somebody home. You would never leave them there for that. So I think it's very common sense. What you would do is obviously you'd put on whatever you need. You would do your assessment, get your vitals, get all your data for me. You would provide any treatments that you felt were necessary. And once you did those treatments, if you felt the patient responded, you would contact me or contact whoever the med control telephysician is, and there would be a consultation, and you could take as an order whatever the physician said. If the physician said, I need you to transport in, well, then you transport in. But if the doc says, you know, this is not emergent, can follow up in a clinic, we can leave them there. The doc could say, you know what, why don't you have the person go to after hours via their own vehicle or something like that. That's how I see this happening, and that's what the protocol basically says here in the process point. So the alternate treatment plans that are under there, at home, transport to an alternate. If it's during the daytime, we could even send Mrs. Smith to her primary care physician's office. I think there would be some logistical issues in this day and age with all the things going on right now, but it is a hypothetical. We could call and say, hey, you know what, she's not very sick, but she probably should get seen sooner than later. Can you accommodate her? Yeah, bring her in, and you could transport her there if it would allow. So I think that this is a protocol that really gives us some tools to do a lot more common sense medicine. But I think we need to iron out some wrinkles first with the video conference part of it. So I will try again. Unfortunately, I'm in conference calls until about 5 o'clock. But I would like to try again, in particular with the leadership from Marshall, to work out some of the kinks. Once we get that, and after my conference call that starts at 4, we'll know more. And I do want, hopefully we'll be able to roll this out soon, and we can communicate that via email to all the services. But we'll see what the regional folks say. If it's the regional, again, you might be talking to a doc like Doc Masterbrook, who's in another county, or you might be talking to Chris out in one of the West Coast counties, and that's fine, Chris Mulligan, as long as all of us agree to that. And so far, all of us as med control docs have agreed to that. So it doesn't matter who you talk to, as long as you put in your note who you talked to, what advice you were given, and that you did it. What questions do you have about that? Oh, it says, what app is Dr. Chapman talking about? The app I'm talking about is an app called eBridge. eBridge is an app that is a national company that in response to this emergency has allowed their services to be used for the duration of the emergency. eBridge is the name. I'm sorry if I said it wrong. And that's something that would have to be loaded by your supervision onto your computers or phones. I have it on my phone. It seems to be pretty straightforward and easy. It looks like something that if we can't figure out, if you handed it to a 4-year-old like my 4-year-old, they would probably figure it out in 30 seconds. You can download it free from the App Store. It's called eBridge. I'm sure that the leadership of each of the agencies can also put it on your work-related tablets. But I used it on my phone, and the video part at least worked well. I think the folks from MAFA are here, and they could probably tell you a little bit about their end. Nick or Mark, if you're on, if you could comment about what your experience was.
So far, it seemed to work pretty good for us. We could see you, we could hear you at first. I'm wondering if you go in your app settings, if you have your microphone off, or, but the video was clear. The audio, when we did have you for a second, was good. It does seem pretty easy to use.
So, and it's one of those that if the app failed or if the situation failed, then you might still have to transport in, but I think it has potential. I see another question. It says, with rumors of ibuprofen worsening COVID-19 symptoms, should ibuprofen be held when treating pediatric fevers? So this is a tricky booger, and the reason I say it that way is there's very little research on a lot of things. There's a lot of rumors. There's rumors about ACE inhibitors, ARBs. There's rumors about ibuprofen. At this point, there is not enough research to definitively answer that question. For my kids, if they were to develop fever, I would still use ibuprofen. But I can't tell you that there's enough literature out there to say one way or the other. But there certainly is a lot of rumors. But again, without being able to have a large group of people who are positive and controls in place, it's hard to really know. But for me, I have not found enough information out there to not use ibuprofen.
Hey, Dr. Chapman. This is Adam from Albion Community Ambulance. I saw a large uptick last week in response to welfare checks coming from dispatch, sending police and an ambulance. Is that something that can be curtailed a little bit? I mean, it's the police go because for access and stuff, but I don't see why an ambulance needs to go, especially if there's not a known medical problem.
That's a tricky question, and I hate to keep saying that, but the purpose of a welfare check, if it's done right, so the hypothetical would be, I tried to reach Grandma. Grandma's not answering the phone. Grandma's very sick. We tried the neighbor, but the door was locked. Nobody could get in. You know, there is the hypothetical that Grandma's down on the ground. She sustained a fall, couldn't get up. And when I say ER doc, we've had plenty of those come in. Slip and fall, can't get up. We've also had people who've coded or people who are found dead. So it's hard for me to give a blanket answer to that one because think about it. If the police showed up and the person just fell or was barely sustaining, they're going to need your support anyway. And the idea is to get you there as quickly as possible if it were a medical situation. So as much as I would love to say those annoying welfare checks that are always perfectly fine, we could suspend them. We can't really because there's a few times when they're not okay. I hope that helped. I didn't give you the answer you want.
No, that's not the, I mean, there's no clear-cut stone answer for that. It's just that we haven't been going on welfare checks And now all of a sudden we're dispatching an ambulance with the police on every welfare check. So, I mean, I don't know what their criteria is or, in dispatch, but that seems to be a huge uptick since this started.
Let me look into that further. And I will warn when I say that I will do my best to look into that further. We're all rather strained, and we're not a resource-rich county, so I'll do my best to look into that with help from my friends at the college.
Okay, thank you.
I have a question. Hello.
Absolutely, Betsy. Good morning. Good afternoon.
Yes. I think the intent of this protocol can help us all immensely, but I'm honestly pretty fearful about the hospital side. For my whole career, there's always been a pretty big shortfall in the hospital as far as ER physicians knowing what protocols are. So if I'm confident that the EMS agencies can push this protocol out, and we can eventually all adopt the eBridge app and use that. But how is this being shared with all the ER physicians? Are they going to all have the eBridge app on their phone? Do you guys have a main computer there? Do they have access to see what these protocols are, so they know that we're actually following, a state protocol that's been accepted by Dr. Fales?
So the reason I'm laughing, and I don't laugh disrespectfully, but you're sharing many of the concerns I have. For Calhoun County, if this works, I want to be involved. But the regional level, they're not just wanting to dole this out to any doc. This is for your med control authority medical directors. So Mastenbrook, myself, Chris, whose name I'm forgetting all of a sudden, these are the med control docs who should, keyword, should know all the protocols. Now, do I know them inside and out? No, but I have the app on my phone to look it up. I don't really feel comfortable with the general ER doc who works here, works there, works in this county, works in that county. I don't want them necessarily doing this right away, especially in the beginning. Now, they were talking about having the residents in Kalamazoo who have already finished their pre-hospital rotation, possibly doing it under the supervision of Mastenbrook and others who are teaching it. So I'm a little more comfortable with them because the docs also work out in the field in Kalamazoo County. But if I were to give it access to Doc X, who's a locum here in Calhoun County, that's putting you guys in an awkward situation, and I don't know that it's appropriate. The doc's not going to know the protocols. They're not going to know what's in your bag. I think that responsibility falls on me and the other med control docs. So it may be a situation where you're waking me up all hours of the night if all else fails.
Oh, don't tempt me.
I know a few of you on this call would be more than happy to do that. But that said, this is an emergency, and I've always said I will be there for you in any way that I can. I may not be the smartest or the brightest, but I will at least try to back you up and provide you anything I can to help. As Betsy knows, often correcting me when I make a mistake.
I don't know what you're talking about. I have a question for Julie or Vince. Do you guys know why you didn't go live with the eBridge when it was like last week when I thought you were going to?
Well, we couldn't go live with it in Calhoun County because Dr. Chapman hadn't approved it, and we don't have the eBridge app on our phones yet for Logis, so we couldn't do that.
Right. But I did have a couple calls where I called a local ER doctor, and because I didn't know anything about the app, I thought it was just telemedicine. Call your local PMD, and I called and did a couple calls with Dr. Len out of BBC, and it was simple sore throat. Just had it for 5 days, no fever, no cough, and we left him there. But it wasn't a telemedicine thing. It was just, I didn't realize what it was at the time.
And I do get concerned about that because if one of my friends from the college can put the protocol back up under section 5, process, letter E, it says, if patient clinically appears to be a non-emergency patient, contact med-controlled telemedicine physician for consultation using MCA-approved EMS telemedicine application.
Yeah, I didn't realize that was not happening yet.
And that's okay. You know, this is one of those things that we're responding to an emergency. We're in a state of emergency on the state and national levels. So nobody's going to slap your hand because you did what was right. And you called med control and you were directed by the physician. But I think they are really foot stomping this telemedicine part of it. Mm-hmm. And for me, I think that includes some element of video through one of their applications. So I think that in order to do that, then we have to use this telemedicine app. And I think we can safely say after our call earlier, or wait, last week, today's Monday, last week, that we have tentative approval if everything goes well. So I'm happy to further test it with you, Julie, or others, if we're at that point.
As soon as they get it on the phones, because I'd really want to check it with our Logis phones, which is our dispatch phones for the units. And I know that they were working on getting us the username and passwords associated with it, but I don't know that they have been installed yet.
Okay. So as soon as they are, and hopefully they're working on that, as soon as they are, I'm happy to try this out further. Any other questions?
I have a question about nebulized treatments. Are we going to try to reduce those and maybe use inhalers instead? Or is that just not part of what we're looking at?
Well, I will tell you, in the hospital, I have cut down on the use of nebulized treatment significantly because a nebulized treatment aerosolizes droplets, which would be a high-risk situation for all of you. At the same time, though, there's a shortage of metered dose inhalers, MDIs. So what I'm encouraging is if you don't need to provide the treatment, don't. And that's hard to say because I know the safest option is to give you MDIs, but that's a multi-use device and you'd be using it once. So it's not very practical, very expensive, and I have only 43 in this entire hospital right now, and I cannot get more. So it's one of those things that I can't just change out everything. But if a person does have an inhaler, they can be encouraged to use it.
Okay. Now, would it be maybe something put out there, something, but not do it in the back of the truck unless absolutely necessary? Because, like you said, it's a closed-in box.
If you're, as much as if you have N95 precautions, if you have an N95 mask, feel free to do an aerosolized procedure. However, I would be very cautious. I would be very concerned about doing nebulized treatments unless absolutely necessary on people in this emergency situation. If you do have to, try to make sure you have a mask on, preferably N95 mask if you can get access to them, because it is aerosolizing droplets, and droplets are how these are spread.
All right, thank you. That answered my question.
So I can provide about 5 more minutes. Again, happy to answer any question, but I do need a break before I go into the Region 5 conference call.
Dr. Chapman, this is Mark Burke. Do we have a sunset on the emergency policies or protocols that have been put out, or are they just going to be rescinded at some point when they deem it's necessary?
Well, we have a good guy up there at the top, Fails, and if I know Fails well enough, he's going to see how these things work, probably publish a paper or two, and they would more than likely become some aspects of these permanent. But I'm supposed to tell you that technically these are emergency only, and as soon as the emergency is lifted, these protocols will no longer exist.
Okay, that answers my question. Thank you.
But if we all know Fails, some of these will likely stay on.
Will you know more after the 5th district call if they got the emergency physicians and a rotation, or how they're going to manage the telemedicine aspect of that?
So the initial part, and I have to clarify because unfortunately my hospital obligations have been such that I have not been able to be as involved with that as possible. The initial thought was we would each MCA, which normally there's a medical director and a vice or some kind of equivalent of that, each would offer 20 hours a month or something like that. And that would allow each of us to be a rotation covering all of the regions. So let's say it's my night and I say I'll do it, I'll cover for 24 hours. I would take the entire calls from Region 5. So that was the initial thought. I don't know if they've changed since then. That's the call I will find out in just a couple minutes. Is there any other questions before I end this? Anything at all?
Dr. Chapman, I do have one question.
Sure.
We send our first responders out to these calls and they appear to be pretty benign, but as you arrive, then seeing temperatures are up, if there is confirmed as they are at the hospital, is that brought back? How is that transmitted back to us? Is that through the hospital, through the ambulance, or?
So if you have exposure to a person, and this is where I have to lean on you, when you're doing your medical charting, mention the agency, first responders who are there if at all possible, because what's going to happen is it's very easy for me to see paramedic A and paramedic B were there, but I might not know that Fredonia Township sent somebody or something like that. So if you can note in the record, it will help me. What will happen is the county will likely reach out to the agency or the township and then me. I get the name of everybody and phone numbers, and then I call and talk to you. So you'll find out from either from me, Colin, or from the county. So if they say, if you're paramedic X and you say, Bob from Fredonia Township, or even you just say, Fredonia Township was on scene, provided this care. If you put that in your note, that will allow the county folks to do enough of a epidemiology study to figure out who it is. So you'll get it from the county, you'll get it from me.
Okay, thank you very much.
And it has worked. Like I said, I've talked to 2 people already, and I won't tell you what agency or anything like that, but I have talked to 2 individuals who are exposed, and the system seemed to work really well. I'm also asking, though, so that depends on a test being positive. I've reached out to both of the hospitals in Calhoun County, and I've asked their chief nursing officers to help me. I want to know before that test comes positive. So if you transported a person that you thought was, I don't know, a syncope, and they get to the hospital and all of a sudden that person's admitted in full precautions, airborne precautions, I want them to send me a note that says, hey, there may be an exposure. That way I can start monitoring you guys and talking to you guys sooner. So that I haven't seen it happen yet, but I have reached out to them to get that information. A little earlier monitoring to keep you guys as safe as possible. All right, I do have to get ready for the next call. This is last call out for questions. Any other questions I can help with, folks? If you do have questions, I'm going to give you my email. It's mchapman, C-H-A-P-M-A-N, @oaklawnhospital.com. There may be a little bit of a delay because I get a lot of emails right now, but I will do my best to respond to you. If it's something emergent that you need answered quickly, my cell phone, which takes text, is 810-730-9576. If it's emergent, call, otherwise text, otherwise send me an email. And I'll do my best to respond to you as timely as possible. Thank you guys for all that you do, guys and girls. Thank you everybody for all that you do. And I'm here with you and I will do whatever I can to help you. Thanks again. Stay safe out there.
Thanks, Doc.
Thank you, everybody.